Our next speaker is Dr. Stephen Schwartz. He's the Amundsen Professor of Ophthalmology and the Chief of the Retina Division at Jules Stein Eye Institute and the David Geffen School of Medicine. We all talk about the triple threat in medicine. Well, Dr. Schwartz is a quadruple threat. In addition to being an accomplished clinician, surgeon, and researcher, he's an innovator. Innovator in new technologies, both in drugs and devices, and he's a leader in clinical trials testing the use of stem cell-derived RPE cells to address various forms of retinal-related vision loss. The title of his talk is Stem Cell Therapy for Retinal Disease. Please welcome Steve Schwartz.
Well, thank you so much for that kind introduction. You left out one of my proudest accomplishments, which is that I was a Nesburn Award winner about 30 years ago. So let's keep that on there, please. I'm getting, oh, there we go, back up a little bit. So I'm going to talk to you this morning about stem cells. I work at UCLA. We are very privileged to have the Broad Center at UCLA. I have no financial interest in anything in this talk. I do want to say, let's just turn the lavalier off for a sec because it's getting a little reverb. I do want to say it's amazing to hear Napoleon speak. It's just amazing. I don't want to jinx anything, but no. Let me just say, the Nobel Committee's late, Napo. They're late. You really deserve it. When I started in ophthalmology, and I'm like choking up, when you take care of people who are going blind before your eyes, in your hands, when I started in ophthalmology, I was doing my fellowship in Europe with 5 of the people who wrote papers in Napo's talk, and we were trying so hard to manipulate angiogenesis in the macula. It not only is a form of blindness that's super common, it's super fast. And you can't imagine, people look at me, even this week, patients looked at me and said, look, I have cancer. I care way more about going blind than I do of dying from cancer. I use my vision 100% of my waking hours. It is a massively impactful thing. And we literally sat around in London trying to figure out ways to pharmacologically mediate these blood vessels that we would remove surgically, that we would burn with lasers, that we would irradiate. I mean, it's like the transition from barbarism to elegance. Stunning. So that motivated me. In fact, when I finished my fellowship, we were just studying interleukins and things to try and modify, and Napoleon Ferrar's paper came out. And the first thing I did when I got to UCLA was I booked a flight to Genentech, and I went and talked to this woman. I want to say her name was Beatrice or B or something like that, who was running the Avastin, it wasn't even called Avastin then, and the Rufab program, which was the name Rufab V1. And I was privileged to give the first dose of Lucentis, what is now Lucentis in humans, and I was involved in 15 clinical trials at the time, and my coordinator, Rosaline, who still works with me, come up to me and said, I don't know what this is, but we should do more of this. It was incredible. And so I've been really, I say to the young investigators in the room, humbly, we stand on the shoulders of giants, and we are privileged to have one of them among us today. Probably many of them, no offense to the other giants in the room that I don't recognize, but really amazing. Common themes in our work is to try and be impactful, to prevent blindness, to restore sight. We at UCLA and in my lab try and address major causes of blindness. I've always believed that curing a major disease is just as hard as curing a minor disease. So I try and go after the big dogs, and we apply fundamental science to major clinical issues by translating science into clinically applicable interventions, and try and drive drug and device discovery and new treatments largely through collaboration and translation, but also in the lab, and create momentum to get the whole of ophthalmology going. And that's really, it seems so obvious, but it was really a lesson learned for me with that first group of patients in the Lucentis trial, in that very first presentation at ARVO in 1999. We presented the first 27 patients, and it created an explosion. Most people thought I and we were crazy. And they were probably right, but it really was an amazing thing. And I'll just say that when we talk about why it's only a 50% or 70% decline in blindness with anti-VEGF drugs, we'll come back to it. It's really our fault, not the drug or the drug biology's fault. So aging is associated with a dramatic increase in a wide range of diseases, cancers, cardiovascular dysfunctions, metabolic disorders, neurodegenerations, and even in the absence of identifiable disease, physiology of organs and tissues decline throughout life. And aging in the absence of disease is a fascinating topic, and within both differentiated cells and adult stem cells, we see susceptibility to intrinsic and extrinsic changes during the aging process. Intrinsic changes would be genomic damage, aggregated proteins, telomere erosion, mitochondrial dysfunction, and exposure to extrinsic factors, for example, might be inflammatory cytokines or, Marlboros. In regenerative medicine, two big barriers, transplant medicine, two big barriers are tissue shortage and rejection, and they become really, important drivers of this discussion. And you can see the waiting list. This is an old slide, and the transplant list is pretty divergent. It's still pretty divergent, and so we've been working really hard on tissue engineering. And I'm going to speak to you today about stem cell-derived retinal pigment epithelial programs for the treatment of macular degenerations. And I'll try and introduce this to you anatomically, physiologically, and so on, and then we'll talk about some long-term follow-up from a pilot trial that we did, again with the idea of driving the field, not iterating a proposed treatment with one try. It just doesn't work that way, right? So we've just done one human trial. It's spawned a bunch of other trials, and for that I consider it successful. We'll talk about the immunosuppression issues, the source of the transplant tissue, and whether they should be embryonic or induced, the immunosuppression issues, and the delivery issues. And they're all kind of fascinating, and they bring together both medicine and physiology. So for those of you who are not ophthalmologists, this is an eyeball. This is the business end right here, the little target on the back wall, the macula. The rest of it's not that important to me. I do like to rehang the wallpaper, but there are lots of places where stem cell studies are being funded and going forward in the eye, and really interesting work being done with photoreceptors. We're going to hear about that later today in RP. But I'm concentrating on the retinal pigment epithelium, and this is some cartoon work that we have for a chapter coming out in a textbook series called Tissue Engineering. And what you see here is the retina. What's wrong with this picture, and it's really hard to capture in a cartoon, but I just want to drive this point home. The retinal pigment epithelium are a monolayer at the bottom of the retina. But what's wrong with this picture is that the rods and cones, the outer segments, about 25 rods and cones are served by each RPE cell. So in this cartoon, it looks like 2 or 3, but the scale's just hard to capture in a cartoon. So you can just think about that as we go through this. The RPE is really important. Dysfunction and death are sort of a final common pathway to photoreceptor loss. Multiple causes of blindness lose the RPE first, including dry AMD. It's not to imply biologically that this is where the pathology lies, but this is just the first cell line that goes. It's a highly differentiated monolayer. It's polarized but non-synaptic. It's surgically accessible. And we have ways of directly visualizing it in the clinic, multimodal imaging. And you can see some path slides here in this cartoon from Dean Bach. So this is a cartoon that I used in a series I did with Eric Kandel from Columbia University, and you can see the light coming in through the retina, captured by the outer segment of the photoreceptors. And in macular degeneration, the RPE is gone and the photoreceptors are truncated and the light just doesn't have anywhere to be sensed. So to be repetitive, critical cell line for vision, necessary for photoreceptor survival, highly differentiated, non-synaptic, final common feature of important causes of blindness, surgically accessible. We can image it both anatomically and functionally. And I'll show you some pretty pictures of photoreceptors. This is my favorite new picture of a photoreceptor. Can you click on this slide? It's got a video. Maybe I can start. Oh, I started it. Never mind. This is a tomograph from the Nano Center, Microscopy Center at UCLA, which is a UC-wide resource. It's an incredible microscopy center there. And we're doing a tomograph through an outer segment of a primate rod. Pretty amazing anatomy. And here's a three-dimensional reconstruction. I'll see if I can, whoops. See if you can click, make this video run. It just is a 3D reconstruction that, there you go. And so you can see if it runs. One more time, click that arrow. Okay, take my word for it, it's really cool. And we can just map out the anatomy, the microanatomy of the rod outer segment at the junction of the photoreceptor inner and outer segment, which is biologically a really interesting area. So what we did in these trials is we take some human embryonic stem cells, we turn them into retinal pigment epithelial cells, we inject them into the subretinal space. We ask them to do a lot of things in this trial, all of which can be improved. We ask them to survive the surgery. We ask them to engraft, polarize, form a membrane, and improve the neighborhood and not cause an immune response. And so there's a lot of asks there, and there are lots of bioengineering ways that we can deal with all of these things, but it's a start. And the idea is, of course, we transplant the RPE, the RPE comes back, and the photoreceptors are healthy. Here are some I'm going to just click through a few examples of the types of imaging we can do in the clinic. This is a histopath section of the retina. This is an OCT scan that's done more frequently than any other test now in ophthalmology. It's about a 5-minute test, and it gives you the pseudohistologic, very, very high resolution layering of the retina. We also have all these other ways of measuring the macula, including adaptive optics at very high magnification, and we can do all of those in the clinic. So here's an OCT of an eye with dry macular degeneration. The retinal pigment epithelial layer stops, the photoreceptor outer segment layer disappears, and blindness has ensued. And so we can look very carefully at these layers and follow these patients without biopsying them in the clinic over time and correlate that with their vision. So it's a very exciting way for us to study these patients. We also can study the relationship of the vitreous gel to the retina, called the vitreoretinal interface, vitreous gel retina. Traction or pulling on this very delicate, refined sensory tissue can cause all kinds of problems, as you can imagine, and that's what keeps us busy surgically. We also have fluorescein angiography. This is the optic nerve. This is where the macula once was. This is an area that's lost due to its retinal pigment epithelium and therefore overlying photoreceptors and underlying choriocapillaris due to dry macular degeneration. And we can take pictures of this by injecting this small molecule sodium fluorescein into the peripheral vasculature and imaging it. Here's a functional imaging test called autofluorescence, where we can measure the fluorescence, the autofluorescence of certain molecules that are parts of the visual cycle when the rod outer segment is recycled by the retinal pigment epithelium. And this is sort of normal, this is sort of abnormal, and this is very abnormal. This is missing. So we can predict, based on the relative hyperfluorescence of this lipofuscin in collecting in the retinal pigment epithelial cells, where the cells are going to degenerate next, where the macula is going to degenerate next. And this is another UC-wide imaging project that we do in collaboration with Berkeley and San Francisco, looking at adaptive optics of cones in situ. I should add in situ of a graduate student, because this isn't quite ready for clinical trials yet, so the graduate student sits there with a bite plate. But it's amazing, these pictures of the photoreceptors in situ, and this is reflectivity. Now, one interesting point with these studies is registration. So registration means, can we go back to the exact same spot? So all of the clinically available imaging devices now allow us to do that with relatively high accuracy. So we can go back over time and measure, at least image, with relatively good specificity, the exact same area of the retina, down to microns, which is pretty amazing when you think about it, that we're doing that in patients. So let me update you on the long-term follow-up. It suggests a good safety profile that may be acceptable. We can talk a little bit more about the source of the transplantation tissue and the delivery. And here's another cool imaging slide of all of the same macular hole, all different imaging technologies. And you can get, it's like the Monsanto ride. It used to be at Disneyland. You get further and further and further into the cell, right? And so, oh yeah, one other important point. This is a paper we published with Austin Ruerda and Jackie Duncan, UC Berkeley, UCSF, and UCLA. And what we showed in this paper, it's a very busy figure. We can lose sight of the cones with adaptive optics. And we used to believe that they were gone. Turns out they're not gone. They're what we call dysreflective. So without true histopathology, even with our fanciest imaging devices, we're leaning a lot on these imaging devices. Like as ophthalmologists, we think, okay, something's missing on the OCT, therefore it's gone. No, it's just no longer in the image. What we proved in this paper, or showed in this paper, we think we proved it, is that this photoreceptor area, these cones that were dysreflective, actually came back. So they were dormant or dysreflective for a time. And in the natural course of this one orphan disease, came back over time. Very, very important when you start to think about transplanting the retinal pigment epithelium, which is just deep to the cones, but you really want the cones to come back. So people would say, well, look, if the cones are gone and you put retinal pigment epithelium in, how are the cones going to come back? Well, it turns out from another disease, we've learned that maybe the cones aren't gone. They're just harder to image and dormant for the time. So it's an interesting deal. Now, ophthalmology, for those of you who don't know it, has a huge spectrum of macular orphan pathology. Huge spectrum. Stargardt's disease, Best disease, PXE, and a number of others. All are unmet needs. They're all blinding without treatment. They all have phenotypic variability, virtually all with genotypic variability. Common feature is RPE atrophy. And I'll just give you a few examples here. Stargardt's disease, and I won't spend a lot of time on these. Pretty good orphan, blinding disease, loss of retinal pigment epithelium. Here's an autofluorescence image. Best disease. Looks like an egg yolk under the macula at the beginning. You can see the OCT. This is the corresponding image. And over time, it becomes RPE atrophy, just like the other image I showed you, loss of retinal pigment epithelium and photoreceptor outer segments. Pseudoxanthoma elasticum with angiogenesis. This is something I would give Dr. Ferrara's drugs to, but there's also another condition where there's just widespread retinal pigment epithelial atrophy, as shown here on wide field autofluorescence. Macular telangiectasia, this is the one I published that AO on, again, loss of RPE and photoreceptors. So there are a whole bunch of these orphans, but here's the big kahuna, is AMD, 80% of which is dry. So 20% of which we treat with anti-VEGF drugs, hugely important, as I mentioned earlier, but 80% of this is very slow-moving neurodegeneration that we can't. It's like the Alzheimer's of the eye or prion disease of the macula, if you like. I put this in here. This is just cataract surgery that's happening quickly for two reasons. One is because it's being performed by a UC Irvine graduate, and two is because there's about 2 million cases per year. And I put that in there to show you that after the first paper came out for clinical use of anti-VEGF, and then Dr. Ferrara's papers came out, we're now giving 2.5 million injections a year of his drug in the United States. 2.5 million injections a year. That's a massive impact. Now back to dry AMD. There are about 2 million new cases a year of dry AMD. And we've been going after dry AMD really hard. Genentech Roche gave a very valiant effort with a complement factor D inhibitor to try and slow this disease down. Big spend, failed phase 3s. Close though, really, really close. Different phenotypes of dry macular degeneration, loss of the macula. These are all end stage. None of these, in my opinion, are good targets for stem cell transplantation. And I'll bring up one other point here that's a little bit interesting. I get asked this, and I'll come back to that when we want to hit the disease question. Why did I study both macular degeneration, age-related, and Stargardt's macular disease? Because they're very different. Stargardt's is in the young and has a different pathophysiologic etiology. AMD is different. And the reason we did it is because of the Brooks membrane differences. We're very concerned that our cells that we're transplanting in solution or suspension will engraft. What will they engraft upon? It's a membrane called Brooks membrane. In Stargardt's, their kids are under 50, so it's less senescent Brooks membrane. AMD is a very senescent Brooks membrane. So that's what we did. And we also put it in suspension to start with because it was univariate. Regulatory agencies, specifically the FDA, really like one variable in your study. They don't like multiple variables. And this leads to the question, is the substrate necessary for survival, engraftment, and polarization? It may well be. We don't know yet. So what did we do to the cells? We had to prove in the drug development or development of a complex biologic a couple of things: purity and extent of differentiation. We did that with these markers. Here are some purity tests showing upregulation of the RPE-specific genes and downregulation of the STEMI genes. Function, we showed with qualitative fluorescence or phagocytosis of fluorescent particles. We can show graft survival at 9 months in animals with the human cells here, anti-human mitochondria, anti-bestrophin, combination image, all in the monolayer in the mouse. In the trial, we immunosuppressed patients for a week before study with big-time solid organ immunosuppression. That's low-dose tacrolimus and mycophenolate, and then a monotherapy for another 6 weeks. So this is big-time immunosuppression. Cannot find another paper in the literature where patients in this age group were immunosuppressed systemically. Cannot find another paper in the literature. And it was really complex. And I can tell you, I didn't do it myself. We had a lot of rheumatologists on board for this. We followed the patients very carefully, very rigorously. We had an important committee, data safety committee, looking at all these patients. So again, back to the cartoon, normal macula, rods, cones, retinal pigment epithelium, Brooks membrane. Here's the diseased macula. The retinal pigment epithelium is gone. The rods and cones are very compromised. That's late-stage disease. Remember, I made the comment a moment ago, I don't want to treat late-stage disease. When you do drug development, you have a target product profile, but you also have a target disease profile. For me, treating people with end-stage dry macular degeneration who can't see the big E on the chart, 2,400, 2,800 count fingers vision, really doesn't make a lot of sense. What makes a lot of sense to me, and their rods and cones are long gone, their choriocapillaris, the underlying capillary bed, is long gone. What makes a lot of sense to me is genotypic-phenotypic correlation in treating them earlier in the disease. This patient's about 20/40, same patient, different imaging modality. We know where they're going. We know clearly where they're going. So this is kind of where they're at in the cartoon schema. They've lost some of their RPE, they lost some of their photoreceptors, and what we want to do to this patient is we want to put a dose of retinal pigment epithelial cells here, regenerate or rescue, more precisely rescue this layer, and create a macula that can add vision for 1 to 10 years as a first step in regenerating macular function. So what we did in our papers and in our project was I chose an area not at the center of vision, here where there's macular atrophy, and you can see in this cartoon the large choroidal vessels visible here in this area of atrophy. We put the bleb here in what I call a transition zone. This is the transplant bleb right after surgery. This bubble or blister under the wallpaper lasts for about 3 to 4 hours, and the RPE that's there sucks it down, and the cells are trapped between the neurosensory retina and Brooks membrane. And the reason we chose this transition zone was because this area, and here are some more pictures of the transition zone, this area mimics or recapitulates the center of vision earlier in the course of disease. We know that this area has compromised retinal pigment epithelium. We know that this area has compromised photoreceptors. We know this area is diseased and about to go, but it's not gone. And so what I wanted to do no harm, stay away from the center. This area, the center was already dead. I wanted to do this transplant in areas that were living and mimicked the course of the disease much earlier, back in time. And you can see that here in this bleb from one of the first patients we transplanted. This is just 150 microliters with about 100,000 retinal pigment epithelial cells in suspension injected into this little area right here. And so, again, autofluorescence testing, that's where the bleb would go in that particular patient. Early in the disease, right? Not big, great patches of atrophy, 2,400, rather get them at 2040 or 2050. And so here's the bleb, and here are the cells, both the transplanted cells and the retinal pigment epithelium, engrafted, polarized, and rescued. So here's the cells come from the GMP lab. We disaggregate them, dilute them. They come to the operating room. We put them into the syringe that we're going to inject with the tubing. We used a commercially available cannula that had to have the right type of surfactant lining the inside, and this is the day of the first transplant patient. This is when magically all the international fellows show up and something exciting. Somehow it has more allure than the beach in Santa Monica. And here's the surgery, and what we do is we detach the gel from the retinal surface, from the optic nerve. This is a vitrectomy surgery. We're removing the gel, and here's the injection, choosing that transition zone. Here's the atrophy, here's the normal retina, here's the area that straddles it. Poke through, inject, and that's the whole transplant. So it's pretty straightforward if you don't have to open the retina up and slide a big sheet underneath. And you'll see I'm going to switch lenses here in a moment. So that's the first human stem cell transplant in the retina. This is a wider view of the same eye, so the optics flipped over. And then what we're going to do with, I'm just showing you the bleb there, and then what we're going to do is what's called an air-fluid exchange, where we're going to fill the vitreous cavity that's now free of vitreous gel with air to try and keep the cells where they belong. We don't want them spilling out onto the retinal surface, the front surface of the retina, where they could cause all sorts of proliferative issues. And you can see the air bubble going in right there. And that's sort of cool looking, but de rigueur for the retinal surgeon. And we put a paper in the Lancet that was just to show the first two again to stimulate. Oh, this is a funny story. I was giving a lecture the other day with a friend of mine who sent me this. I don't take the Lancet journal, even though I've published in it. And he sent it to me with a big piece of paper over the front of this and said, "Congratulations, your article's in here." It was like a giant Post-it. And I just left it in the corner of my office in a stack of journals for a long time. And then about 2 years later, I was cleaning up and the Post-it had come off, and I didn't realize that I had this on the cover, which was great because I had something to give my mom, because she was about the only one who cared about that. So atrophic macular degeneration, here's the big atrophic area, here's the area we transplanted, and here's the area a few months later. You can see the retinal pigment epithelial cells forming sheets. This is the area I'm most interested in, but this is what the post-transplant eyes tend to look like. You can see the pigmentation increasing over time. Of the 18 patients we did domestically, we did another 18 in Europe. 72% had increased detectable transplant success by measure of pigmentation at 18 months. Look at here's a little transplant. Look at the photoreceptors coming back right over this area. So the stem cells improve the neighborhood. They don't just improve the retinal pigment epithelium, they improve the neighborhood. Pre-op, shortly thereafter, later thereafter, and here are close-ups of the same thing. And here I put this in for Barry just to scroll through. You can see actually the ellipsoid zone coming back in this transplanted area, which is pretty exciting. You can see autofluorescence of the cells right after transplant, and then that was the next paper in the Lancet. And essentially, anatomic evidence suggesting successful engraftment. Here's a pathologist with Stargardt's disease, actually, and you can see pre-op, and then at 1 year, at 2 years, and at 3 years. The retina looks different here because his cataract has subsequently come out. Vision never changed in that patient. It never improved. It was too late for him. But you can see a really nice transplantation in that patient. Here are the vision curves. Take these with a grain of salt. We measured vision as a safety measure, not as an efficacy measure, and there's no control group here other than the fellow eye. Here's the fellow eye, and here's the transplanted group. And you can see that at a year, there's a big difference between the fellow and even at a couple years, there's a big difference between the fellow eye and the treated eye. You may be asking yourself, why does the fellow eye have a bump in vision right after the transplant? And the reason is there's a very, very strong effect called the placebo effect. And it's super real. Because if you've been blind for 20 years and you get a pat on the backside and some vitamins and say, go stay independent if you can, you're pretty depressed. And all of a sudden you meet some crazy person who says, I'm going to give you a stem cell transplant. You get pretty excited. And all of a sudden your depression lifts, your signal processing gets a lot better. What was a very blurry big E that you're reading out of your peripheral vision, you're trying a lot harder. And that's what this is. It goes away pretty quickly. But it's real, super real. That's why we have control groups. Here are some more 24-month follow-ups. The lines stay separated. Adverse events were largely related to the immunosuppression. Really hard to immunosuppress the elderly, hard to immunosuppress everybody. The visual acuity data, as I said, seemed to indicate stability or increased vision. But the cells were extremely well tolerated. We did not see unwanted proliferation. We did not see tumors. We did not see teratomas. And so we were pretty excited about it. Again, no true control groups, fellow eyes only, low numbers, immunosuppression difficult, particularly in the AMD population. So in these phase 1 trials, they were successful in my mind for 2 reasons: long-term safety, and it spurned a lot of new trials coming out. We're continuing with the suspension trials. We also have our UCLA-centric iPSC program, and There are a bunch of other trials. One is using a patch. It requires a big tear in the retina, a big hole in the retina. You slide a patch. You grow a sheet on plastic or on Parylene or on a variety of scaffolds, even polyester. You put it in, you laser around it, you get a big giant scotoma out here, but you might do well in the macula. That's the cartoon of the patch. iPSC is really fascinating. I'll just take a second to talk about this and end because I know I'm about to get my red light blinking here. iPSC resets the cells. It mimics meiosis. So it allows essentially a new individual with the same genome. Features of aging are not present in the iPSC cells, and we're confirming that in the RPE. So here's a young cell, all these different parameters of aging. Here's an old cell, they're all different. You put them through iPSC, they're all young again. We now turn them into RPE, they seem to be all young again. So it's like creating infant or newborn RPE from the patient specific, so no need for iPSC. iPSCs have been really tough, but we're really getting close because we're able to grow them at scale now. This is a really cool patient who's got his iPSC. We've got 24 lines of iPSC RPE growing right now in the Broad Center. We've had 2 FDA meetings. We're getting ready to start transplanting patients right now. It's a daunting process, but if you use GMP, you can do this with just commercial things, and these are all available commercially. Even the CRISPRs and the TALENs and all this stuff, you can edit the genes if you want to. But it's tricky, and there's a lot of regulatory steps involved, but you can do it. We're not editing in the first group. I'm of the belief that if we can give you fresh RPE, and we can get what we saw in my patients that had the human embryonic stem cell transplants, they got 5 years of improved vision before it started to regress with very low doses. Here again is a beautiful, very pure RPE cell line grown from skin fibroblasts in an 85-year-old patient. It's amazing biology. Not mine. I'm just borrowing it from the people in the lab. I put it on the cover of our Springer book. For those of you who are interested in, this is a really cool little book because it summarizes all of the regenerative strategies that are out there right now, some of which have already failed, some of which haven't gotten to the clinic yet. So, to conclude, great future. We stand on the shoulders of giants. The University of California, whether it's San Diego, Irvine, UCLA, San Francisco, Davis, have made major contributions and continue to shape our field. The lessons from today is innovation is exciting and fun and can be impactful. So please go invent, discover, or build something new. Thanks for your attention. The truth is there's no literature on that, no really well-studied biology on that. The eye and the subretinal space are considered to be inside the blood-brain barrier, so immunoprivileged to an extent, but in disease, we have no idea. And in the transition to disease, we have no idea. It's a great question. I don't know. Actually, retinal pigment epithelial detachments are really interesting pathologically. It's almost like a sloughing, right? It's for some reason, in the young, there's a very good adherence to Bruch's membrane. It's a sort of a basement membrane, fibronectin layered sandwich, and they are hooked in pretty tightly, and as you lose that, they can blister up. The RPE pumps fluid from the subretinal space into the choriocapillaris. Nutrients come from the choriocapillaris into the pigment epithelium, so it's a loss of pumping function, or Bruch's membrane becomes lipid-laden, and the pump just hits, instead of hitting wheat bread, it hits buttered bread, and it just builds up like a blister. We don't really know the answer to that question, but there are all sorts of different types of RPE functions.
We see this in eyes with chronic retinal detachment. The RPE is still there. So I was wondering if these huge drusen have anything to do with impairing fluid movement toward the retina.
I think they do. I think it's fluid going from the subretinal space out towards the choriocapillaris that's impaired by the drusen.
Okay.
I think that's correct. We don't, and actually we see drusen typically go away when we repair retinal detachment for some reason. We also see drusen go away with anti-VEGF therapy. So we see subretinal fluid collect from abnormal blood vessels. We treat those abnormal blood vessels with anti-VEGF agents. The retina flattens down, and the drusen load is completely different. The drusen profile is completely different. We're not sure why we spend whole symposia arguing about that. And you can imagine that at the end, there's no clear answer.
Well, these stem cells are young, that's another point, I suppose. Maybe
Right.
they're
Exactly.
not there long enough to.
The RPE has so many functions that if we can restore semi-healthy RPE there, we think that we could probably possibly make a benefit over time. So the patients that we, excuse me, implanted in the AMD cohort in this group all had very end-stage AMD, 24 to 600 or worse, sometimes even hand motions. In that group of patients, typically drusen are gone or calcified. Drusen are not permanent. They're impermanent features. They are little mountains of debris and different layers of Brooks membrane. They're many, many different types of drusen. They're between sublayers of Brooks membrane, between the RPE and in different places, and they tend to come and go. They can come and go with laser, they come and go with age, they come and go with fluid, they come and go with detachment. In our cohort, we did not have many patients that still had drusen, and we did not transplant near any drusen. We've looked for that, so we don't know the answer to what the effect on drusen is yet. Yes, so that's a good question. Visual follow-up, long-term. Who's going to ARVO next week or in 3 weeks? That's when we're presenting the long-term follow-up. But I'll give you a little teaser. The vision finally comes back to the control group at 5 years, more or less, as expected. One thing I didn't really emphasize here is the dose of RPE cells. This is a phase 1 safety study, lowest dose possible, away from the center of vision. This was just to make sure we weren't going to kill anybody. And we still saw a very unexpected visual bump. So, and it lasted for 5 years. We're about to go to much higher doses, much different immunosuppression regimens, different ways of transplanting the cells. We've refined the manufacturing, we've refined the production, we've refined the preparation, the transplantation technology, the immunosuppression. So there's all sorts of stuff that's about to change in the next round. And that's just that one source of iPSC cells, of embryonic stem cells. We're also going to be doing it from the other side without immunosuppression with the iPSC cells, the autologous cells. Yes, sir, that's what we were just talking about. The vision improved in a large percentage of them over the first 5 years, and then it's sort of coming back to where we'd expect it to be like the other eye. So about 5 years of visual improvement. But again, I want to emphasize that study was not done with visual acuity as a specified endpoint other than we thought it might go down, not up. It was a safety endpoint. And they were very, very end-stage patients.
I think if you have any other questions, you'll hopefully be here for lunch.
Yep.
Thank you very much.
Okay, thank you.